Meeting is being recorded because it is a public meeting. The recorded will be posting on the Commission's webpage shortly after the meeting. TBW may also be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. Vicki Lowe, Chair of the Universal Healthcare Commission, will now call the meeting to order.
All right, thank you, Mandy. Thank you, welcome Commission members and members of the public. It is now 2:01 and we're starting the meeting a minute early. So we'll call the August 10th meeting to order. And this is our 13th meeting of the Universal Healthcare Commission. I'd like to start by giving a land acknowledgement. And just like to acknowledge that all of the lands that we live on across these United States, and especially here in Washington State, are Indigenous lands that belong to our Indigenous ancestors. And we just want to thank them for the care and their stewardship of the lands and the waters since time immemorial, and just remember all that was given up by these people in order for us to have what we have today. So thank you for being here. And again, a warm welcome to everyone joining us today. I see lots of members of the public. So let's start with an overview of the agenda. Doing the welcome and call to order. Mandy will do the roll call, and then we'll take a couple minutes to approve the meeting summary from the June meeting. We have a 15 minutes set aside for public comments, and from after that, we'll hear from Pam McEwen about the FTAC, the Financial Technical Advisory Committee, and then we'll hear about the Commission's initial guidance on FTAC for Medicaid. And so starting another conversation, we've talked about Medicare and ERISA, and now we're looking at Medicaid. We set aside 60 minutes for a presentation from the Washington Health Trust about Senate Bill 5335 that was introduced. And we'll be able to think more about what is in that bill and how that aligns with the work that we have moving forward. And then Liz from HMA will lead us in discussion and prioritization of our transitional solutions. And then we'll talk about the 2023 LEDGE report and our next steps, and then adjourn at 4 p.m. Now I'll turn it back over to Mandy.
Thank you, Vicki. I'll proceed with roll call. I will call members for the first.
Sorry.
Can you hear me?
Yeah. I forgot
everything
about the question.
Oh, no, I'm sorry. Go ahead.
Okay, I'm sorry. You know, every time we do roll call, we do a question, and this, because we're meeting on Zoom and we don't really have the opportunity to get to know each other very well. So just some questions to kind of help with that. And this month we are asking, what was your favorite movie you've seen this summer? Okay, now go ahead with the roll call, Mandy. Sorry.
That's great. No, thank you, Vicki. I'll call on members by their first name in the order listed on the agenda, which is alphabetical order by first name. When I call on you, please unmute your microphone and let us know you're here and what is your favorite movie that you've seen this summer. And then please mute your microphone again. Chair Vicki?
Present, and my favorite movie that I saw that I got to see with almost all my grandchildren and my daughters was Elemental.
Oh, that's cute. Senator Ann? Senator Ann? Bidisha?
Hi, I'm here, and I really enjoyed the Mission Impossible movie.
That's great. Thank you. Dave? Dave?
I think Dave's on annual leave.
Okay. Senator Emily?
And I think Senator Randall is getting married like this month, so she might be otherwise busy.
Yeah, she might be. Estelle? Estelle? Well, I know Jane's here. Jane?
Yep, I'm here and I'm sorry, I'm off camera. It's been a heck of a day and I'm eating my lunch. I'll come on camera after I finish eating. Sort of dark, but women talking. Great movie.
It's a good movie. Joan? I do know Joan might not be available today. Sorry, were you going to say something, Jane?
Nope, I was just agreeing that Joan's out.
Yeah.
For a bit.
Representative Joe?
Yes, I'm here, and frankly, I can't recall seeing any movies this summer.
No movies? What about a TV show? TV show you've been enjoying over the summer?
Frankly, nothing really stands out, so I would say, not a lot of TV watching either. I'm enjoying watching the Mariners.
Oh, well, that's a good one. Catch any live games?
No, not this year.
All right, well, there's always next year or later in the season. Kristen, and I do believe Kristen will also be absent today, but I will call her name anyways, just in case. Kristen? Representative Marcus?
I am present and I am off camera too. I am in transit to my office, so I will be on camera shortly. And no movies, which I was kind of surprised. I was thinking, but I am enjoying making my way through Ted Lasso.
That is a great show. Mohammed?
Hi, Mandy. Yes, I don't think I've seen any movie this summer, but I'm having fun with the kids, and now that I know I'm missing out, so I'll probably watch something. But thank you.
We got a list started from the group. Nicole? Nicole? Stella? Stella? Okay, I will turn it back over to Commission Chair Vicky Lowe, who will facilitate review of the meeting summary and public comments.
Just have to unmute. Thank you. So we turn to the second tab in your commission book. There was a recording of last meeting in June posted on the webpage, and there are notes here for us to vote on. Or is there any discussion of the meeting summary or proposed changes to the summary? I was not at the meeting and I apologize for that. So I have no comments. Is everybody okay with what is in the notes? Okay, I take silence as agreement, so please speak up. Otherwise, I propose that the minutes are accepted without change. Any second?
I'll second.
Thank you, Patricia. Any further comments? All right. All those in favor of accepting the minutes from the June 13th meeting, please say aye. Aye.
Aye.
Any opposed? Okay, motion approved. Next, we have public comments. The public comments that we have received since our last meeting can be found under the third tab in your commission book. And we did receive quite a few. I think there was more than 30. So thank you for those of you who were able to comment. We have 15 minutes set aside for public comments. We will allow the individuals who signed up ahead of time to go first. Mandy has a list. And if you've not signed up, but would still like to make public comment, please raise your hand. After we've been through the list of people who signed up prior to the meeting, Mandy will call your name. We have 90 seconds for comments. If that's enough not enough time to make your full comment, please remember that you can send us written comments. Once you're called on, please state your name and any affiliation you might have before speaking. Please do not raise your hand more than once. This helps ensure that everyone gets a chance to speak. Again, you're welcome to provide comments in writing, and we appreciate those of you who have done that. And we do have a large number of people signed up to provide public comment today. So again, we're going with 90 seconds per person, and we may need to reduce that to get through more. Mandy, how are we doing?
Yeah.
Does that 90 seconds seem right? Or
Yeah, 90 seconds is great right now.
we have the time up for you, so that to help keep track, and we encourage public comments to be focused on the current materials today on the agenda. If we have time for public comments, if we are due, you're welcome again to submit comments in writing. So Mandy, will you please start with the names of the individuals who have signed up for public
I
comment?
will, and I apologize if I pronounce anybody's name wrong. Mike Wayrish. Mike. Do we see one, Mike?
We do, Mandy. I give them the panelist invite. They have not accepted it yet, but I will send it again, but they are here.
Okay, thank you so much. We'll give it another minute.
Hi.
Hi.
It just took a while to get in, huh?
Great. Wonderful. Thank you so much. Would you like to provide your public comment?
Yes. No, I don't see my notes because I can't minimize this. So, okay. So I'm Micah Wyrock, and I've worked for over 35 years in nonprofit management, specifically generating revenue. And I'm going to address rural access to healthcare, such as in my county, Cowlitz, which has about 100,000 people. We're increasingly having difficulty accessing healthcare. When my father was dying 2 years ago, I couldn't find palliative care. My father had dementia and had difficulty going anywhere. Finally, with hospice, we were able to receive care. But that hospice facility has since then significantly reduced their presence in our community. With my mother, the rheumatologist recently left Cowlitz County, and many elderly and other people are having to spend a whole afternoon driving and attending to appointments when many of these people are not healthy. I suggest that the commission look at ways to use financial incentives and in order to bring providers to our community, at least on a part-time basis, if not full-time. Thank you very much, commissioners, for your time and for listening to me today.
Thank you. I have Madeline Bishop. Madeline Bishop.
Yes, I'm here.
Great.
Okay, I'm a retired state worker, and I'm able to purchase insurance through the Healthcare Authority, and I support a universal health care plan for Washington, and I'd love for it to be based on the existing uniform medical plan with no prior authorizations. And I'd like to ask the Healthcare Commission to move forward and set a deadline for your report to the legislature and identify what legislators will introduce and co-sponsor the single payer plan. Identify a communication strategy to support passing the single payer plan, and identify who will take the lead on defending and funding any court challenges. thank you so much for your very hard work, and I will let the next person speak. Thank you.
Thank you. Faye Michaud? Faye Michaud? I'll move on to the next person on the list. Lisa Gaynor. Lisa Gaynor.
Yes, hello, that is me.
Okay.
Hi, I am a constituent of Cowlitz County. I am a widow and I am in between health services right now due to my employer doesn't provide insurance, and I am a widow, and I have had a very hard time understanding the insurance coverage and getting something that will truly work with me and for me. And my daughter also has had a situation where she has had to purchase insurance also. And we were able to find affordable plans, but the confusion began with, once you pick a plan that you can afford, finding providers that actually are taking new patients, finding the coverage that you actually signed up for, which is a lot different once you have that coverage than what was described in the initial information. And just having something that most people take for granted, which is easy, good coverage. All you do is make a call. Maybe there's a small copay and you move on. I just want real coverage that we can all afford. Thank you.
Thank you. Ronnie Schur. Ronnie Schur.
Hello. My name is Ronnie Schur. I'm the president of Healthcare for All Washington, and our organization recommends that the Universal Healthcare Commission and Finance Technical Advisory Committee focus on 2 of the transitional solutions that you have developed. I added details in my written comments to you, but I would like to acknowledge that 1, on the plan for Medicaid beneficiaries, is that it's a difficult plan or difficult to do. It's not like moving a person from Medicaid onto a specific plan. It's not like moving checkers from one square to another. It's more like moving a chess piece, because we have to find a matching plan that has access, just like a previous speaker shared. However, I have hope that since we've witnessed the frontline workers at the Healthcare Authority showing how much they care about these Medicaid beneficiaries and how much they can pay attention to these details, I have hope that this will be a good transition. The second one was about low-income Medicare beneficiaries, and the commission has done a lot of work on that. I'd like to see you build on that work. At Healthcare for All Washington, we're pleased to see this 2-prong approach for transitional solutions like this, but also reviewing the Washington Health Trust that you're going to talk about today. So thank you for that, for leading us towards universal coverage for everyone.
Thank you. Chris Curry.
Hi, Chris Curry, Healthcare for All Washington from Spokane. In an effort to jumpstart a discussion of the Commission's vision for Washington's universal system, I've included a suggested draft vision in the materials for this meeting. It's based on the key design elements inventory prescribed in SB 5399 and expanded in the November 22 report. It is also consistent with both federal Medicare for All bills, the Washington Health Trust Bill, the Oregon Universal Health Care Task Force report, and the California Single Payer Bill. And it further clarifies how the commission can address the inventory and the overall direction it intends to take. If members could discuss and agree on the overall direction, it would greatly facilitate the task of prioritizing transitional steps. Steps that will need to be taken anyway as parts of the vision would receive the highest priority. Adopting a common vision will also give the public and the legislature a much clearer picture of what the final product will look like, and it will help generate public excitement towards its accomplishment. Thank you for your work.
Thank you. Warren George?
I am Warren George. I am a past member of the Oregon Task Force on Joint Task Force on Universal Healthcare. I wish to express continued appreciation for the work of the Washington Commission, and thank you for that. I also want to announce briefly that the Oregon legislature passed Senate Bill 1089, and the governor signed just this week a bill which creates a governing board for universal healthcare in Oregon. I also hope that you will read my submission, written submission, setting out the diagramming healthcare flows and including some hard logic about what sets a single payer system aside from other alternatives. Thank you very much.
Thank you. Michael Hubbard?
Yeah. I'm a retired actuary, although I never worked in health. And I lived in the UK for 11 years and was covered by the NHS. And one of the things about the NHS that was wonderful was that you went into, they call the doctor's offices surgery. You signed up with a doctor, and there were no co-pays, and there were small co-pays for prescriptions if you were under 62, but otherwise there were no co-pays for prescriptions either. And anyway, I think one of the huge problems with the current system we have is its complexity, and several speakers have addressed the problems they have. And when you have a universal system, as in the UK, it's far simpler. You get better care, and statistically, the outcomes are better. And in this country, we spend twice as much per capita on healthcare as they do anywhere else, and we get far less for it. And anyway, I support a single payer system, and that's what we need. Thank you.
Thank you. I'm gonna circle back around and see if Faye Michaud has showed. Okay. I'm gonna move to anybody who has their hand raised. I see Emily Bryce.
Good afternoon, Commission members. I'm Emily Bryce, Deputy Director of Northwest Health Law Advocates, an organization that's worked to expand access to affordable care in Washington for over 2 decades. Thank you for the opportunity to comment as you consider transitional solutions. I'd like to suggest a rubric for decision-making about those transitional solutions. Any solution should make progress towards all 3 intent criteria identified in the Commission's enabling statute, which directs the Commission to work towards 3 goals. First, immediate and impactful changes in the current healthcare system to expand access. Second, establishing preliminary infrastructure to create a universal health system. And third, efforts to improve health outcomes for all residents. These 3 items can serve as a guidepost as you consider next steps. Based on that rubric, I suggest prioritizing the following initial solutions to help Washington to prepare for universal health care. First, continue to address undocumented immigrant health. Second, fill gaps in benefits and affordability for Medicare enrollees. Third, support efforts to unify health coverage, eligibility, and enrollment systems. Fourth, explore universal enrollment screening at key life transitions. Fifth, work towards consolidation in state healthcare purchasing, where doing so could expand access. Sixth, study the state prevalence of underinsurance across all market segments. And seventh, explore opportunities to make care more affordable by pegging to a Medicare benchmark. I'll offer further information about these recommendations, which I understand are numerous, in written comments submitted later today. Thank you for your consideration and ongoing work.
Thank you. Mohammed, I see that you have your hand raised. Is that intentional? Do you want me to circle back to you when I'm done with public comments, or?
Please circle back with me when you're done with
Okay.
the public comments.
Okay, sounds great. Thank you. Mason? I just see the name Mason.
Can you hear me?
Yes.
Yes. Hey there. Yep, I'm Mason. I just want to say, healthcare would have meant a lot to me growing up. My family really didn't have money to pay for medication just to help us with our seizures, and that really affected us in school. And it'll probably affect my children too, and having something to just help out would mean a lot to just me and my family. I really hope this goes through, and yeah, I just want to thank you for your time. That's all I have to say on this matter.
Thank you. I don't see any other hands raised at the moment. I'll just give it one opportunity to see if anybody raises their hands additionally. Mohammed, I'll circle back around to you.
Thank you. No, I just wanted to thank those who have taken the effort to submit their public comments. Just I wanted to add my story actually to just basically remind my fellow commissioners and everybody else. The inaccessibility of our health insurance right now is really hurting a lot of people. My story, like I'm the deputy director of a small nonprofit organization. We provide healthcare insurance to our employees. And right now, for the last 2 years, I've been paid half my paycheck just to cover my 4 children and my wife and myself. So, I mean, if it's that expensive to me, I can only imagine what it's doing to, other Washingtonians. So I just wanted to add my voice to that, to the comments. Thank you.
Thank you. And I see Roxanne Thayer has raised her hand.
Hello, can you hear me?
I can, thank you.
Thank you. I'm calling to let you know a few things that are happening out here in the field in Washington State. One is that the Kitsap County Board of Health has declared just last month, July 2023, a healthcare crisis in Kitsap County. That's due to several reasons. One, CHI Franciscan takeovers and shutdowns of medical facilities and hospitals in that county. Same thing is happening in Eastern Washington. And then the other thing is the vast amount of junk insurance plans that several people have referred to. For instance, Molina is not accepted in Pierce County. My daughter has to go from Tacoma to Sequim to see a dermatologist who will accept her insurance. There are so many junk insurance plans out there that have been put forward as a step towards universal health care. It's not helping. We need to move to universal health care and then make the steps to get there with having already made that commitment. And then finally, it is essential to the people in Washington State to have healthcare access, and healthcare access that is not faith-based. And finally, the Universal Healthcare Work Group and the Washington Health Trust both showed beyond a shadow of a doubt that moving to single payer universal health care, Medicare for all would save the state and the citizens of the state billions of dollars. Thank you.
Thank you. And that's everyone that I show for public comments. I'll turn it over back to you, Vicki, Chair Vicki Lowe.
Thank you, Mandy, and thank everyone for providing your public comments. We look forward to those who are going to offer more in writing. Next, I'd like to welcome Pam McEwen, who is going to give us an update from the Financial Technical Advisory Committee, or FTAC. Pam, thank you for joining us.
Thank you. Thank you, Chair Lowe, and good afternoon, Commission members. Today, I'm going to be reporting to you on FTAC's July meeting, and my remarks should be quite brief because our July meeting was the first of a two-part discussion. I want to draw your attention to tab 4, which has the detail that we covered in that meeting, if you want to go into more detail. As you know, the Commission directed FTAC to examine pathways to include ERISA in a universal system and provided guidance to FTAC on this topic. Our July meeting was focused on information gathering on ERISA issues, both at the national level and here in Washington. We heard from two presenters. The first was Professor Carmel Shakar from the Harvard School of Law, and she provided an overview of ERISA, which included the evolution of the court's interpretation of ERISA preemptions, ERISA preemption impacts on state innovation, particularly universal healthcare initiatives. And we identified kind of with her potential areas of opportunity for looking at eligibility, which would be participation in a universal health plan for employers, pay or play with meaningful alternatives, provider incentives or some level of regulation, and potentially a payroll tax on all employers, which is the method being pursued by Oregon. FTAC also heard from your own commission member, Jane Beyer, senior health policy advisor to OIC, on how ERISA has played out in Washington state. We heard about segments of healthcare market for which ERISA preemption does not apply, and health policies in Washington that have and have not brought ERISA challenges, kind of going into why that might be. We also examined policies in Washington that haven't been challenged and why they haven't been challenged, and could be beneficial to FTAC's looking at the pros and cons of options. So in September, our plan is to dive deeper and to look at the options that I just reviewed and potentially other things that may come forward. And what we'll do is we will assess the pros and cons of each, and then the plan is to bring recommendations back to all of you. I know that the next topic coming up is guidance from you on Medicaid in terms of eligibility of Medicaid enrollees. So we will be looking forward to that. Thank you. And if you have any questions, please let me know. Please, and maybe we have a few minutes for questions now if there anything comes forward. Thanks.
Thank you, Pam. I'm sorry, my husband's chosen this moment to work on our roof. So if you hear any banging, everything's fine here. Just want to check and see if anybody had any questions. I know this is an interesting topic. I worked on the self-funded plan for the Jamestown tribe, and it's very familiar with ERISA, and just thinking about how we can bring this coverage into universal health care without violating any laws.
It's a very complicated topic.
Yeah. Any questions for Pam? All right, thank you, Pam, and we look forward to the future work on this. And now, sorry, I'm gonna hand it over to Liz from Health Management Associates, and she'll walk us through initial guidance to the FTAC for the Medicaid coverage.
Thanks so much, Vicki, and thanks, Pam, for your report on the ERISA conversation. I think we can go to the next slide, Angela. Really, as we've been clipping through the year with FTAC, they have been looking at different programs and focusing on eligibility. And just a reminder, it's not about whether or not these folks are going to receive some type of equal benefit. I think what we've seen so far is with Medicare is that while the commission while the direction has been to not design around Medicare. There is a plan to address parity and make sure that folks who are Medicare beneficiaries have an opportunity to get coverage that brings them up to the level or makes it equal to what the universal plan is going to provide. So looking forward, again, the next FTAC meeting is going to focus on ERISA, but we're planning for 2 meetings out and need to identify speakers and experts. And in advance of that, we just wanted to pose to the commission, we can go to the next slide, Angela. What are the questions that you would like to have FTAC ask and answer regarding Medicaid and how it relates to the universal system, so that we can start looking for experts to be able to help lead the FTAC through that conversation? And just want to open it up to our commission members, to who many of whom have a lot of expertise in Medicaid, to find out what you all think the FTAC should be focusing in on. Oh, there's Jane.
Hey, Liz. So, I mean, I get one of the things that would be most helpful is sort of getting a sense of what other states have done with their 1115 waivers around Medicaid eligibility. I mean, we've made a lot of progress toward making it a non-categorical program, but there are still restrictions that we deal with. So are there any other states that we can look to that have been creative around trying to expand eligibility? Because it seems like most of the action on the recent Medicaid waivers that we've been seeing, including ours, relates to expansion in the scope of covered services to finally really take a look at social determinants of health. But the eligibility is still a question out there.
Right. Okay, that makes a lot of sense.
And I would add to that, sorry, that, I think one thing that in Indian country that we're always frustrated with since the passage of the Affordable Care Act is that classic Medicaid, classic Medicaid, which is for the most vulnerable populations, still has all of those asset limits. And is there some work going on around aligning the the coverage, the MAGI income with what people on classic Medicaid have, and getting rid of those the asset limitations? I think that was huge, I think, for our people to be able to come on coverage.
That's really helpful. Other commissioners? I'm looking through everybody's pictures to see whose hands are up.
And I'm wondering, there has to be somewhere some kind of crosswalk of coverages between Medicare, Medicaid, and maybe PEB. I think
We've been talking about trying to put something like that together because we'll need it for eventually trying to design and get the parity. So I don't know if something like that actually exists.
Well, I imagine there might be somebody on FTAC that would know if one existed. It would be just a question to ask.
Yeah. Is there, yeah.
Is there an existing one?
Maybe one of the FTAC members has done it in their free time. So that's a good question. Other thoughts, Pam, as the liaison, do you have any questions about this?
I'm unmuting. I really like the comment about a crosswalk of benefits because I think that that's a stronger, and we hear this from a lot of the people coming on public comment that they are completely confused about why this is covered in one plan and then it's not covered when I move to something else. So I think it would be helpful to look at that. I think the eligibility question that Chair Lowe brought up is important. I think there's some federal barriers there. So then as you look at a universal system, what happens? I also am curious is about how you evolve to a universal system with Medicare. How do you bring those people forward? And I'm not sure, I think that would be something that we could, when we bring in expertise to talk to the group, we can talk about that, how you get from here to there. and how you manage the eligibility issues and kind of the chasms between the different systems.
Yeah. Vidisha?
Is it possible to create a map of providers in Washington State who are not accepting Medicaid? So, I mean, that's one thing I've seen in literature, that because of low reimbursement rate, a lot of providers don't accept Medicaid patients. And if we don't change the reimbursement rate, then, you know, that problem might persist no matter how much we change Medicaid in other ways. So I don't know if that's a possibility or not, to get kind of like a, you know, like a spatial distribution.
I'm going to look to my healthcare authority friends and Jane OIC, if you all have something like that.
Provider directories are really difficult because they're constantly changing. There isn't a page-based one either. And so the only way to rely on that is by commercial directories, and that doesn't count for populations.
Right. And the only, I mean, the other challenge with provider directories is that while in some cases, and Mandy worked on these rules, like for mental health providers, we require the carriers on the private health insurance side to know whether a provider is accepting new patients. That's not necessarily a case. So Vidisha, it's like we work really, really hard to make sure that the carriers, and the HCA works hard to make sure that the Medicaid MCOs have an adequate network of providers that have contracted with them. But absent asking for additional information, it's really hard to know how many of those providers that have a contract are actually willing to see or actually have room in their practice to take care of folks. It's a challenge we share across Medicaid, Medicare, and private insurance.
Vicki, did you want to say something?
I have a different thing to talk about, so I'm going to leave that topic first.
Yeah, I wanted to close the loop on Vidisha's comment, because I think what it actually points out, though, is it sounds like you'd like to know more about what are some of the key issues for folks in Medicaid, though. I mean, access potentially being one, but really just trying to surface when we want to address what's going on with Medicaid for the universal system, we want to know what the problems are.
Right, both kind of the demand and supply side. I mean, we have talked about the reimbursement issue, but you know, somebody pointed out about they just don't have a geographic access to it. That you know, their daughter has to go to a different place just to see a dermatologist. And I don't know if they have Medicaid or not, but I just think that access, like a physical access to provider, I would like to know, you know, different reasons for it.
Got it. Great, Vicki.
And I know where we live, we not only have the reimbursement issue, but there is housing issues where providers have more trouble finding housing in rural places. But you do bring up a good point. So with Medicaid, I'm wondering, you know, reimbursement is a big issue. And so if we're looking at universal health care and we don't have the federal waiver, the federal legislation to include Medicaid, even if we do wraparound services, so, you know, bring the level of benefits to the Medicaid patient up to the same level as universal health care, we still have to deal with the issue of reimbursement for providers. So I guess my question to the FTAC would be what are our boundaries on that? What can we actually legally do? You know, we've got the primary care certification work group that's been meeting, and I'm not sure how that connects with the Medicaid program, but I think that's important to connect in there too.
Great. Yes, it makes sense why after eligibility we talk about provider reimbursement, because in particular, because I think there's an intersection here. So, okay, so what we can do on rates for Medicaid when we're dealing with the access issue, what are the key issues for Medicaid beneficiaries, understanding the chasms between the systems, between Medicaid and other systems. Folks asked about a crosswalk of benefits between Medicaid and other healthcare programs. Lots of focus on wanting to know what if there can be more done to align with MAGI and with classic Medicaid. Jane, you particularly pointed out what have other states done with expanding eligibility and this kind of alignment with Medicaid using waiver authorities, pointing out that, yes, we've done a lot on trying to do health-related social needs, but we need to go back and look at some of the flexibilities around eligibility here. And then also finally, the classic Medicaid and the asset limitations. So anything else? This is all, I think, really helpful in terms of trying to structure that conversation that will happen in November. I believe it's November. And we'll come back again and ask more questions before we get there. So thank you. All right, back to you, Angela, or to Mandy. I'm sorry.
I think it's me.
Yes.
Sorry, Vicki.
That's okay. So I'm just going to pass it off. We're excited. We've got set aside time today to hear from Andrew Stackhouse and Erin Georgian, is that right? From the whole Washington, to give a presentation on the Washington Health Trust Bill. So Andre, Erin, are you ready?
Thank you all. I'm ready to kick it off. So I just want to start by thanking the commission for, perfect. Yeah, I want to thank the commission for having us today, giving us the opportunity to really dive into the details of Senate Bill 5335. Also, a big thanks to the senators Cleveland and Hasegawa for helping arrange this meeting. We're really looking forward to starting the conversation on this. We hope it's an ongoing and collaborative one. Next slide. And just a little note, these slides were submitted on the 2nd. We're presenting here on the 10th, but for the latest version of this material, as well as any other supplemental materials, you can go to wholewashington.org/UHCC-presentation. We hope to have some nice stuff up there in the coming days. Next slide. So just to introduce ourselves a little bit before we dive into all the policy stuff, my name is Andre Stackhouse. I'm the executive director of Whole Washington. My background is in information science, and I've worked in the tech industry at small startups like Code.org, as well as big companies like Microsoft. And my political background is mostly in healthcare stuff. I've represented the Democratic Party at the state and national conventions. I co-founded a national group called Medicare for All Everywhere, which is sort of intended to develop state movements like this across the country. And I led the last Whole Washington Initiative campaign, I-1471. But I'm really fortunate to be joined by Erin today, who's one of our most prolific policy consultants on the Health Trust, who's going to really back me up with your really, really tough questions that I know are coming.
My name is Erin Georgian, and I am a technical communications and design specialist by trade. I work supporting community-based health organizations in Eastern Washington. Prior to that, I worked as a physical therapy assistant in Washington for over 10 years. And before that, I did health services in the U.S. Coast Guard. I had the opportunity to sponsor the first initiative that was drafted with the support of Whole Washington, and I've had the opportunity to participate in all the evolutions and updates and processes to get it where it is today.
Slide. So to just give a very brief introduction to Whole Washington, Whole Washington is a 501c4 nonprofit organization founded back in 2017 to really advance the issue of universal public health care at all levels, state, regional, federal. We're probably best known for the Washington Health Trust, which is a statewide proposal that we'll be talking about a lot today, which has been introduced in multiple iterations across both legislation and initiative. And a shout out to Senator Hasegawa for being the primary sponsor of every version of the Health Trust introduced in the state Senate. Slide. And to give a brief history of some of the healthcare stuff that's happened. This is really a lot of the more recent stuff, and we just include this to sort of acknowledge and visualize the way in which we've had our own journey at Whole Washington, starting with I-1600 back in 2018, the first time actually originally introduced as the Whole Washington Health Trust, introduced as a initiative to the people. But every year there has been significant progress made, whether that's us introducing it into the legislature multiple times where it has been improved and gone through additional review, but also important legislation done by the legislature or work done by this commission and similar groups like long-term care, Cascade Care, 5399, which formed this commission. And then actually a fair amount of playtime today will go to the capital gains tax passed in 2021, and then a recent Supreme Court ruling on that. So all of this is highly relevant to the design of universal healthcare. Also mentioned the 1332 waiver acquired in 2022, just to show that a lot of the work that needs to be done to achieve universal healthcare has been happening and can continue to happen. Next slide. So some goals for today. We kind of want to just start real basic with some, broad shared definitions of universal healthcare, set some outcomes and values there. And then the nuts and bolts of how the health trust actually works. We want to go into our proposed solutions to known barriers like ERISA and Medicare integration, and then hopefully get through all of this in time to give you some opportunity to ask us questions. Looking down the line, we really hope that this is the beginning of an ongoing and collaborative relationship with the Healthcare Commission. We think that a great way to continue this conversation would be actually a more detailed discussion with the Finance Technical Advisory Committee, because we've run some analyses on the costs and there's a lot of details there we won't get to today. But ultimately, we want to be co-developers of universal healthcare policy with the Commission that gets recommended to the legislature and passed, so we can really start getting people healthcare. Next slide. So starting at the top with that definition, go ahead. We really like the World Health Organization's definition. So they say universal health coverage means that all people have access to the full range of quality health services they need when and where they need them without financial hardship. Identifies some key elements of that, including universal eligibility, either automatically or through enrollment, a universal set of benefits, so we don't have a tiered system in which some people receive much better coverage than other people, uniform billing and reimbursement, which is a key component to making sure that the costs are shared equitably, and then significant public funding and nonprofit. Another way to think about this is really deprivatization, decommodification. I think those are some of the major differences between what we're proposing here and what we currently have. And one thing we like about this is just, it provides a fair amount of flexibility. It identifies key outcomes, but is not highly prescriptive in the how. And that gives us the room to design a system that's going to be appropriate for Washington State in the current moment. Next slide. This slide, I think, speaks more to the values of it. So King County is named after that guy, Martin Luther King. What does he have to say about it? Of all the forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And that, for us, just keeps in focus the stakes here, the stakes of the action we take, but also the stakes of the action that we do not take. And that we're not just talking about cheaper healthcare or more convenient healthcare. We are really talking about a more just healthcare system, and by extension, a more just society. And so we hope we can come up with something worthy of the namesake of King County. Next slide.
All right, so we wanted to also take a moment to kind of ground it in some of the work you guys have already been working on for a while. So this proposal is a bit of Model B and Model A hybrid. That the models used for your guys are for the fiscal study. What we do want to say is it starts out as a Model B, but it's voluntary enrollment. So it's designed to grow a little slower than the model that you've studied. And it's designed to work towards Model A, recognizing that that's where the biggest savings is, but it may take time to do all the negotiations and processes required to integrate all these things.
So, going from outcomes and values and models, right, the next step we really see is policy. And so the Washington Health Trust is a universal healthcare policy. Next slide.
So the origins of different components of this proposal, honestly, the first section and healthcare coverage and the governance of the trust was originally inspired by the Washington Health Security Trust, which was developed by Healthcare for All Washington. And shout out to Marcus Riccelli, who was the sponsor for that several years in a row, or several legislative sessions in a row. The tax funding was guided by the study that we had done by Gerald Friedman, actually two, we had it updated when we made adjustments. He's an economics professor at the University of Amherst, Massachusetts at Amherst. Technical language was reviewed by Employment and Security Department and the Department of Revenue for the different funding mechanisms. And then a key set of provisions were collected into section 101. And these were the core values consistently expressed by community organizations, providers, and individuals that they felt were really important that guide the trust.
So effectively, the healthcare policy is very, very complicated, as I'm sure everyone knows. But there's sort of three major pillars of what we're proposing here, right? And the first is the creation of public options such that anyone in Washington would be eligible to enroll in them. The second is the generation of the revenue necessary to maintain those public options. And we propose doing this entirely through public financing. And then the third is the creation / coordination of infrastructure to govern and maintain this system. And a lot of that is existing, others would be new. But it basically comes down to those three major goals. Next slide. To kind of put it into a little bit more of a step-by-step, what does the legislation actually do? The first thing is just the creation of the trust itself. So effectively a bank account, the revenues go in, the reimbursements go out. The second is the creation of the Washington Health Trust Board. That's the sort of key governing body of the Health Trust Board. A lot of this will come down to collaboration between the board and the healthcare authority, but a lot of authority is going to be given to those entities to design the specifics of this. And then we'll create some transitional plans, including a health options program and a Medicare Part C plan. And this is to provide some amount of transition for people who may be receiving coverage elsewhere or may be falling into a gap. We want to make sure that everyone is eligible to participate in this. And then the last is to establish the necessary funding, which will be collected and enforced through ESD and the Department of Revenue. Next slide. So we'll be diving into what all of this means, but trying to use the language of the commission as best as we can. We think it's a model A-B hybrid. We think it begins with model B, but over time transitions to model A. And we say the Washington Health Trust is an all-payer model with a pay-to-play requirement for employers. It includes public options for all Washington residents, public health funding for participating community health providers, as well as the financing and transition plans necessary to achieve universal coverage. Next slide. So getting into the real specifics of how we achieve that, we want to go into the design components that were developed by the commission. So all of these categories should be familiar. We just added a little bit of additional detail on our transition plan, things that are fairly specific to our proposal and not necessarily permanent parts of the design. Next slide. So we'll start at the top with governance. Go ahead. And that's the Health Trust Board that we already mentioned. And in the most recent iteration of the Washington Health Trust, we actually added the Healthcare Commission, elevated the Healthcare Commission to be appointed to the board immediately. It is optional, of course, but every member of this Healthcare Commission would have the option to serve on this board. The board is also going to be expanded to include some new members. And then it's going to begin to create certain committees that will be collaborating and representing key stakeholders. So very critical, a citizen committee. We think this is an area where there could be more representation. But that committee is going to be publishing reports and holding public meetings to provide public accountability and oversight. There'll be a provider committee, and that will be facilitating a collective bargaining agreement with healthcare providers and negotiating reimbursement rates on service. And then last, a finance committee, which is going to be maintaining the revenues and managing the solvency of the trust, And we happen to believe that this looks quite similar to the FTAC that has already been formed. So in that sense, you can already see parts of this infrastructure have been coming into place over the last couple of years. And we want to just continue to build off of that into the system that we propose here. The board will be allocating funding to community health providers. And as we said, we'll be playing a very collaborative role with the Healthcare Authority, including on the acquisition of federal waivers. Next slide.
We identified another key responsibility and created some governance structures within the Healthcare Authority. The Healthcare Authority currently provides oversight and accountability to the insurers who administer our publicly funded benefits. So the HCA would also provide that same kind of accountability and oversight to the trust to make sure that they're meeting those goals. Again, this is in line with their current responsibilities. They also provide some structures and support for enrollment, just like they do now for other programs. They'd coordinate the integration efforts and lead all of the waiver processes. Waiver processes can be hard, complicated negotiations. They can be slow. So this bill is designed to leave room for that, but make sure that we're addressing the immediate needs of Washingtons who are underinsured or uninsured right now. And again, they work to acquire the federal waivers and will need the support of the trust in order to make that happen, provide the evidence, support, and infrastructure to show that we can successfully integrate those.
So getting into eligibility, and we want to keep it pretty simple. The big idea is that everyone would be eligible, right? So from the perspective of individuals, we base this on residency. We use the Washington State's definition of residency, which is 30 days. And so we completely define eligibility independently from the social determinants of health. So this is not based on age, income. If you live in Washington, you should be covered by this, or at least eligible to participate. And it's also going to provide eligibility for some non-residents, including students who might be going to school in Washington, workers who maybe are employed in Washington but don't live in Washington, and then in certain family situations, a spouse or a dependent might qualify as an eligible non-resident. Next slide. Similarly for employers, not required to participate, but no employer will be prohibited from participating. So all employers may choose to participate in this system, and they can do that for all of their employees or on a per employee basis. And there's going to be a required health spending expenditure per employee. And so basically that's the means of participating, is to pay that expenditure. This is also completely independent on additional forms of coverage. So if they would like to provide employer-sponsored healthcare, if that employee has coverage from somewhere else, they are still 100% eligible to participate in the Washington Health Trust. Next slide. Benefits and services is more of the what's covered, right? In a universal system, it really should be all medically necessary care. And we define that in an essential benefits package. So hospital services, ambulatory, drugs, mental and behavioral health, lab work and tests, reproductive care, long-term care, pediatric care, dental, vision, hearing, rehabilitative services. All of this is defined in the essential health benefits package in legislation. Next slide. This is an area where the board will actually have a fair amount of authority. And so while this is the sort of required amount of essential benefits, the board has the ability to expand that package. The key component of this is that it is a single benefits package for all enrollees. This is not a tiered system. So if you're an enrollee, you're covered by this benefits package, and there is only one. And we're not going to have a system in which some enrollees are paying more or have better, paying more for better care. From more of an aspirational standpoint, right, part of the idea here is that we're trying to set a standard that all state managed plans can meet, and that through the work of the Healthcare Authority, through the health options program that we're introducing, that we can kind of create a system in which On the back end, you might be covered by this program or that program. It's very complicated, right? But for the enrollee, you feel confident, I'm covered by the essential benefits package. It doesn't matter which state plan I'm enrolled in. So we want to set that standard and raise all state plans to that standard. Next slide. Providers, sorry, I'll pass this one to Erin.
So providers, essentially, all providers would be eligible to accept reimbursement for any benefit that they provided to enrollees. They don't have to be contracted to or have a prior setup. That was just a key element of this. Those fee-for-service rates would be negotiated on an annual basis with providers' input and participation. So the idea here is that providers really want a voice, especially if there's going to be a single rate that we're trying to pursue, really want a voice in that negotiation process. In addition, it was important to them that they could not be denied reimbursement for benefits that they provide, as long as it is within the line of standard of care. When you guys are starting to make out, do funding analysis, it's important to identify some baseline rates. Some assumptions can be made. So for our study, we actually made the assumption that providers wouldn't want to make less than they're currently making now for their total population of benefits. And so those rates vary quite a bit. But if you take and base it on population size and actually come down, it actually produces rates that are roughly 10 to 20% higher than Medicare rates are now. So I would suggest, starting by bringing in providers and also looking at those rates as they would be now. If all of them were the same, what would that total amount of funding look like, and average it out? Next slide. Aligned reimbursement rates are really, really important part of reducing the strain on providers. So the board would be responsible for facilitating negotiations that providers can participate in every year to negotiate fee-for-service rates. They would also offer opportunities for global budgeting type of rates in combination with fee-for-service if they're nonprofit and collaborating to expand capacity. Again, there's transitional rate alignment steps where the healthcare authority would use its authority to the degree it can to provide some reimbursement rate alignments across all the plans. Next slide. Global budgeting, we've had questions about this consistently, so we wanted to point out that global budgeting is designed to give the trust the ability to provide operational funding to nonprofits so that they can expand services. It's not necessarily designed to have the entire operational costs of an organization paid for or a health system, but it is able to do that if there was a region in huge need of services. Next slide. Cost containment.
Yeah, so, sorry, I was going to take this one. So cost containment, I think starts with an acknowledgement that we have the most expensive healthcare system in the world. Our current total healthcare spending in Washington is about $80 billion per year. And, we believe that we have a proposal, depending on exactly how you run the numbers, can save between 5 and 10 billion a year. We think that that's, our analysis sort of matches the healthcare work group's analysis in that sense. But in terms of the specifics of how cost containment would work, this is not something that we legislate in 5335, but we do give the responsibility and authority to the board. And so we expect the board to enact cost controls when necessary without limiting access to or reducing quality of care. There are many different means of cost containment that can be, looked at from other systems. But inherent to the design of 5335, we think are two key means of reducing complexity and eliminating waste, especially administrative waste. So the first is that we have a single essential benefits package, which means that it's not highly means tested. It's not, is this covered? Is that covered? the coverage there is very, very comprehensive and would be uniform for everybody. So much simpler in that sense. And then on the billing side of things, by having uniform rates of reimbursement, there's much less effort that has to be expended in terms of how much is this reimbursed for? Do we need to collect some of that from the patient? We actually, eliminate a lot of those all of those out-of-pocket expenditures and move that into the public financing. So in that sense, we think we can save a lot on billing, and that's where most of that the savings that we project comes from. Next slide. So going from costs into revenues, right? This shows the public financing that we propose. What's not on the slide is all the things that we're not paying. So, for enrollees of the trust, right? Premiums, copays, deductibles, out-of-pocket expenses, all of those things are eliminated and replaced with these forms of public financing, right? So the first is an employer tax of 10.5%. That's per employee, and it's based on payroll. So on the pay for that employee. We'll go into more detail about this in a moment, but this 10.5% is actually going to be required whether you're paying into the health trust or whether you are paying into other forms of healthcare for employees. But we'll just say that compared to what it costs to provide healthcare coverage for a workforce anyway, this is really quite competitive. It is not uncommon for an employer to be paying 12%, 15% or higher to provide healthcare to their workforce. That might not even include part-time, contract, lots of people who are working there. And one nice thing about participating in this system is it completely relieves the administrative burden associated with providing that coverage. So no more admin, no more shopping for plans. This 10.5% would simply be paid, and then the employees are now eligible for enrollment. So that's the employer tax. There's a 2% employee payroll tax, and this is actually a way that cost is shared between employer and employee. So we'll show this visually in a moment, but that 2% actually subtracts from the 10.5%. It does not add to it. So it's a 2% deduction from employee payroll. And again, compared to monthly premiums, this might be pretty competitive compared to what an employee might be paying. But it's it completely eliminates the surprise out-of-pocket expenses, right? When you go to get care, you know that you just go in and receive the care. You're not thinking about cost anymore. That 2% also applies to sole proprietors. And then the last one is an 8.5% capital gains tax. And this was something included to allow us to create a progressive funding structure within Washington State's tax code, which can be quite difficult to work with. And so our analysis shows that about 90% of Washington State makes less than $10,000 a year in capital gains and really would not be affected by this at all. But another little point we want to make here is that this funding structure was designed before the passage of the capital gains tax, and especially before the recent Supreme Court ruling on it, which in our opinion changes precedent a little bit. We've always wanted to exempt people who have the most need for care and the least ability to pay for it from as many of these financial contributions as possible. And that's difficult in our tax code, but we believe that there might be more room for exemption at the bottom than previously thought. And this is something where we're very open to collaboration and revisiting what's proposed here, but we do think it raises the necessary revenue. Next slide. So this just shows that sharing between employer and employee, 10.5% on for employers. That's a required healthcare spending. And then they may deduct up to 2% of that from employee payroll. Next slide. So to see how that breaks down visually, and in this we're assuming that employers fully put that 2% on employees. They may actually cover any or all of that 2% as a benefit of employment. But assuming that they're paying only 8.5%, you see the light blue segment there is about 3/4 of the funding. The employee payroll then, is that section in the middle, and then a relatively small sliver for capital gains. And the more employers who choose to cover that 2% employee payroll deduction, the more of it would be light blue, like you see in that first chunk. Next slide.
So to create a little more context, especially since we use a graduated exemption for this 10.5% required employer expenditures, that graduated exemption is quarterly. So we put this in annual numbers, but depending on like what part of the year an employee, this is making the assumption they work the same amount all 4 quarters of the year. So again, for lower income or lower paid, this was like nannies. This would be folks that are working very part-time, under 12,000 would not have any required health expenditures by those employers. As you move up the scale, 20,000 to 60,000, a lot of our employees are in this range, especially the ones that don't have coverage currently. And you can see that we're talking about $87 a month, ranging up to about $525 a month. Again, this employer would be required to spend this amount towards the employee's healthcare in a variety of ways, but it's also the amount that they could spend to enroll them in the trust. And then you can see that it's even competitive as you move up the income scale. And I'll go ahead and move to the next slide and create a little context, just a refresher about where we are now. Currently, the average employee earns about $57,000 a year. So again, right around that middle mark. The average employee pays monthly $475 for an individual plan and over $1,000 for a family plan. The average cost, the employer-sponsored coverage insurance annual premiums was around $7,700, and for family coverage, it's around $22,000 a year. So under our proposal, we plan on covering kids across the state without any kind of cost to the families. So right away, there would be a benefit to employers who have a large number of families, employees with large families, because there's a really big difference between that number. And then on top of all of that, the average employee pays an additional $1,600 in co-pays, deductible, and other costs that throughout the year to actually get care. Next slide. So we're going to talk about infrastructure. The basic infrastructure that is building on existing structures, with the exception of the board, although again, we suggest using this existing entity to sort of start that process. The board would be acting as an insurer, a managed care organization. And in that way, it would contract with the healthcare authority. Healthcare authority would provide, as it does now, oversight and accountability, enrollment support, and infrastructure. They would also be coordinating those efforts for waivers. The governor and the legislature support this effort by providing startup costs and also reviewing those reports from the HCA and the new trust board and making policy changes as recommended. The Employment Security Department would enforce the required healthcare expenditures and facilitate participation for those employers who want their employees to participate in the trust. As a way to meet that spending requirement. And the Department of Revenue enforces the capital gains tax as it does now. For enrollment, enrollment processes are not detailed in this proposal, and part of that is recognizing that those processes might evolve over time as those integration processes happen and we are able to integrate plans. We can make it more smooth. So initially it's enrollment would be managed by the healthcare authorities so that those who are eligible for Medicaid and Medicare can be enrolled in the right way and our state can receive the funding it needs for those enrollees. It would use the existing infrastructure like the Washington Healthcare Health Plan Finder, again, to meet residents where they currently are in their enrollment processes. And then it would have the ability over time to evolve them. Again, the Employment Security Department is given this role to support businesses, especially small businesses, to transition into a health spending requirement. And with a new requirement in general, this is in line with their current duties for the WCARES Act and for other programs that we have. Small businesses can also get cost assistance from them if they face financial hardship as we roll into this program. Next slide. So working within ERISA, much like was pointed out earlier today, there are some opportunities to bring in line and align spending in the employer market without requiring them to participate. So we can require that they cover their employees, all of them, not just the ones that the Affordable Care Act requires. We can require employers to I'm so sorry. I'm so sorry. So we can require them to spend a certain amount, and we can define what that spending is. We can also cover all kids. In Pennsylvania, I believe it's Pennsylvania, they are using a program to actually cover all kids are eligible to enroll in CHIP. We can create a framework to provide health coverage and cost equity to employees that are not enrolled in the trust, i.e. supplement their employer's coverage if they are willing to participate. And we can work to bring in line, continue to work at looking for new opportunities to integrate employer spending. Next slide.
I just want to add, sorry, just want to say that we designed this plan after the model developed by Healthy San Francisco. So that's a city option plan. It has survived legal challenges on the basis of ERISA. And so we are highly confident in the legality of the design that we propose here to provide this coverage, to include employers without running afoul of ERISA challenge.
Again, just to clarify that the spending requirement is not an obligation to participate in the trust. And even when they're not participating in the trust, if they choose to spend towards their employees' healthcare in another way, they are still contributing to that employee's healthcare. Those options include continuing an employer-sponsored coverage plan for them, direct employee healthcare covering, so covering someone's actual costs or contributing to a health savings account to cover the costs. And it also would include the WCARES Act. Perhaps they want to use a private insurance option, but they would additionally meet their obligation by adding that long-term care coverage. Transitionally, we're going to talk about just a couple of transitions. The Health Options Plan is a transitional plan that would be managed by the Healthcare Authority. It's designed to support the uninsured and the underinsured. It builds on their existing programs to support people who aren't sure how to navigate their health insurance coverage. And it would evaluate and look for any kind of discrepancies or inequities by providing that assistance through a side program that they manage. They can use this to monitor changes in enrollment, to provide oversight and feedback on the process. And long-term, this can also support enrollment in the trust. Medicare integration waivers, just to put it in framework, this one is really looking at having the Healthcare Authority try to pursue a demonstration waiver, recognizing that that might be a difficult battle and requires some infrastructure to be established first. It does instruct the healthcare or the new trust to go ahead and create a Medicare Advantage plan and offer it to the state, those who are eligible to enroll in Medicare. It also leaves some room for the Health Options Program to provide gap coverage for those who are not enrolled in the trust for coverage. Next slide. The healthcare exchange is one of the few that we call out in a unique way in the proposal. We recommend that the funding that's being provided federally for cost assistance on the exchange be phased out and directed towards the trust directly once our state has more than 51% of its residents enrolled in some publicly funded health plan. So that could be the trust, or it could be traditional Medicaid, or it could be traditional Medicare, but it's a publicly funded that could be one of the dual eligible programs for Medicare, but one of the state managed plans, that we should direct that funding directly to the trust, and it would be the only plan available with cost assistance. It does stipulate that the health benefits exchange structure can remain with the healthcare authority and continue to be used as a supplemental structure, either for enrollment or whatever else work that needs to be done and to keep this a sound system. Next slide. This is our transition plan, and it's basically a 5-year rollout of first becoming established and getting that initial funding from the capital gains, helping employers to prepare for the process of required health spending, which actually wouldn't happen till year 4. And so it's like a 3-year rollout. The first 2 is preparing to enroll all of those who have the immediate need, the uninsured, the underinsured who have immediate need, and voluntarily enroll. And then there would be those incentives for employers to contribute towards their employees that aren't currently covered, or who they're not providing enough cost assistance for that coverage, where they could choose to enroll them in the trust. At year 5, we stipulate that the amount that is required, the required healthcare spending by employers, should be reassessed, and the Employment Security Department can adjust that rate if the rate is, we know that there is administrative savings in reducing the administrative burden on providers. So the goal is ultimately, if there is too much funding for this trust, or this process, then you can adjust that rate for providers and do it in a uniform and equitable way. But we do want to make sure that the trust has the funding it needs when it first gets started, and maybe primarily enrolling the lower income residents who are on the lower mid scale.
Okay, so it's a lot of different moving parts there, but to go back to that in a nutshell, like we said at the beginning, the Washington Health Trust is an all-payer model with a pay-to-play requirement for employers. It includes public options for everyone, public health funding for participating community health providers, as well as the financing and transition plans necessary to achieve universal coverage. That's using technical language, it's descriptive, it's the language of the commission. We might phrase it a slightly different way. So for us, the Washington Health Trust establishes a single benefits package and a public option that can immediately begin to offer everyone coverage. It outlines a framework and a transition plan through voluntary enrollment, employer participation, and integration of state and federal programs, which can achieve universal single-payer healthcare. So importantly, this gives us the means to take those first steps to begin to create the framework for universal healthcare, but it will not be universal on day 1, will not be single payer on day 1, but it is 100% achievable. Next slide. We just want to end with some optimism here. Washington State can do this. We lead best with our example. We've done it on so many issues, whether that be drug decriminalization or marriage equality or reproductive rights. Washington has always led federal politics on this. And we know that it can be done on healthcare because it's been done before. So on the left, we have Canada, and the province highlighted there is Saskatchewan. That was the first province to pass universal single payer in Canada. It is not a liberal province, it is not an urban province, but it is a province full of people that needed healthcare. And that movement carried it through to establish the universal healthcare system of Canada. On the right, you have the United States, and much debate goes to whether this can be done at state level or if it should be federal first or what have you. But we highlight the state of Massachusetts to remind us that the last major reform at the federal level to our healthcare system came from the state of Massachusetts. And we hope that the next major reform to our healthcare system might take inspiration from a highly functioning universal single payer system that we develop here in Washington State and put on the table for the rest of this country so everyone else can get healthcare as well. And we don't really think it's important if you call it Cascade Care for All or Universal Apple Health, statewide Medicare for All. The important thing is that it establishes that universal eligibility, that comprehensive essential health benefits package, and really starts to get people healthcare who have not been able to get it before or who have been, just completely burdened by the costs associated with it. So with that, we are so grateful to have gotten the chance to present today. And with whatever time we have left, we'd love to answer your questions.
Thank you, Andre and Aaron. We've got about 4 minutes. Are there any questions?
So this is Jane. I just want to be sure I understand the pay or play component of this. It sounds like, in essence, there's a minimum monthly contribution that's based upon the employer's revenue, and that minimum can be met via either an employer's maintaining their plan or modifying their plan however they want, but whatever the value of that is, or, and you've got, contributing funds into a health savings account or CARES, and then whatever's left over, that's the obligation that they would have to the fund, or am I not catching that correctly?
I think the first thing that I wanted to clarify is that the amount the employer is required to pay is per employee. And it's designed to ensure that they are contributing towards each employee's care, even if it's part-time, even if it's contract. And it's graduated in that way to make that a reasonable cost for an employee who might be temporary or might be contract, might work a very limited number of hours. It's designed to ensure that they're contributing towards each employee. They can spend it in a variety of ways, but for the vast majority of those employees, being able to enroll in this program is the most cost-effective option. Now, we know that there's a lot of employees that already have coverage that they are very comfortable with, and they're hesitant to leave that. And so, at least initially, employers could meet that health spending requirement by continuing that coverage, but it's a specific amount they're required to spend on each employee based on that employee's pay.
Thanks.
Representative Schmick.
Thank you. I got a lot of questions, but I'm just going to ask one. And how are you going to deal with a lot of people who do not trust the government and really are going to be reluctant to want them to put the government in charge of their health care? How would you go about addressing that? Thank you.
I think the first component of it is that this is a very voluntary model, right? From both an individual and employer standpoint. And so in that sense, if people are hesitant, that might be something that they consider over a number of years to see how well it's working. But the other thing is that people don't necessarily always have great feelings about the government or taxes. This is very common stuff, but people also don't have great feelings about their health insurer a lot of the times. So people are very, very burdened by our healthcare system. They have to pay a lot. They are shocked all the time to find that things aren't covered. And then they get, buried in paperwork and put on hold. So I think that, compared to what people are dealing with, we can definitely offer something that provides a better experience.
Yeah, and I would just like to add to that this proposal recognizes that it will take time for people to, for everyone, to be confident, especially those who have been burned by this health system in the past. So I think it's really important to recognize that's why it's voluntary, which is it's designed to give you time to build that trust. You build the trust, and that's how you deal with those issues. You can't force people who have never experienced this type of quality government program to trust it. You have to show it to them have friends and people in their community that are getting that benefit. You have to allow employers to see and compare it to what they're currently offering. I think that's the key. You have to build something and be reliable.
Thank you. Mohammed, and then we're going to move on.
Thank you very much. My question is, first of all, this is really impressive and a very good presentation. I have a question opposite to what this representative just asked. How soon, what is the soonest that this can roll out? Because there's a lot of people that's hurting by the, the existing insurances right now, including myself. I literally have been paying half of my salary to get premiums for my family and myself. That should be illegal, in Washington, anyway, in America. Is there so basically when we talk about health and the needs for healthcare, it might not have a lot of time to it. There are people who are in pain right now or would like to get healthcare right now that cannot afford or do not have, so they might not have years to wait. Is there what is the fastest this can start covering all of Washingtonians, and is there a more quicker option for people that might be in bad shape because of the existing failing healthcare system or health insurance? Thank you. I don't want to take a lot of time, but please tell me if those questions do not make sense or if I need to repeat them.
No, I think I understand. This does make the assumption that it might take a couple of years for the trust to get established. So it has year one focusing on establishing those benefits and reimbursements and the budget, and year two getting those contracts in place so they can start enrolling folks. So the idea is that in November of the second year, so in line with current enrollment processes, meeting folks where they are, is when you'd be able to start. In truth, though, there's a lot of flexibility in this design, in that ultimately it could be kicked off sooner if the board of the trust is able to get those things accomplished sooner, and if the healthcare authority is able to get their responsibilities set up sooner. So in that sense, what can we do sooner than that 2-year mark is really up to the entities that take it over.
I'd just like to add, I have not seen a proposal that kind of proposes a faster, more immediate rollout. The first version of this trust was introduced into the Senate in 2019. That was a few years ago. And I think it's important to reflect on really the fastest way that this can happen is for immediate action to be taken to pass this or parts of this, some form of this. The Health Security Act, that kind of predates this, goes back even considerably further. But the point here is just that, yes, it takes a while to fully realize the systems that we're proposing, but the critical steps are committing to that process and saying, we're going to establish universal health care and we are going to begin as soon as possible. And so, we think that the formation of this commission is a great step, but we want to also just keep in mind that, the real enacting of policy is still ahead of us. And that's something that we should not delay on as much as we can.
Thank you. Thank you for this great presentation, Andre and Aaron. I'm sure there's more questions, but we need to move on. So Liz is going to walk us through discussion on prioritizing transitional solutions. Liz?
Thanks, Vicki. I actually am seeing a text from our organizing group here about whether or not we have enough folks to do a vote on transitional. So I think we are going to continue with questions. Is that?
We can continue with questions. We
Sure.
can also continue with the next slides and not actually take a vote. We could do the slides in the Q&A and walk through the materials.
Okay, so do we want to, okay. Chair
Vicki,
Lowe,
how would
you like to proceed?
Let's go through the slides and at least have the conversation.
Okay.
And trying to think about the vacant position and where that puts us forum wise.
Okay, well, we'll at least just go through the conversation because it's been ongoing since January. And thanks to the folks from Whole Washington, lots of interesting ideas and thoughts. Just as a quick reminder, the commission is charged with identifying and moving forward transitional solutions that would help move towards the universal system that you are charged with designing. Our activity here is to really focus on prioritizing areas for further evaluation. So if we can go to the next slide, please. Just a little background. We started this back in January where we asked commission members about areas they'd like to focus on. The commission then asked the FTAC to put some additional ideas on the table. And so this was back in February, and now we are here where we want to prioritize areas, and we're not going to actually move to making that decision today, but we at least want to provide an overview of what we've heard from both the commission and from the FTAC in terms of areas. Okay, and now I'm seeing that we might be voting. So in any event, let's go to the next slide. Just to kind of explain the process here and how I'm going to walk us through this. This slide will actually shows the array of suggested ideas that we've heard from both the commission and FTAC, and we've gone ahead and grouped them into different categories to help make some sense of it. We're going to go through each category quickly and ask commissioners if anything is missing under that category or if something rises to the top. And then after we do that, we're going to ask about how you would like to move forward in terms of selecting focus areas to dive into in the coming months. And for the report, it will not include the specific policies for this report that we're talking about in just a little bit today, but we will identify the areas for the report that we'll be focusing on. And appreciate the comments that were made during public comment about these ideas and some criteria for how you might want to think about it. So we can go to the next slide. Okay. So the first bucket is our policies and strategies related to affordability, cost containment, and pricing. And the second bullet is capacity and infrastructure. I'm not going to go through each of these items, but I think we have two questions for the commissioners for these two buckets. First, is there anything missing in one of these buckets? And then just sort of keep in the back of your mind as we go through these, what makes sense to focus on and prioritize. So I'll just ask one more time if there's anything in these two areas that you think is worth exploring or that you'd like to spend some time on with the commission thinking about in terms of putting forward a transitional solution.
So Liz, this is Jane.
Yeah.
And can you help me? I get hospital global budgets.
Mm-hmm.
Reduce affordability threshold. What's that? What policy specifically does that refer to?
I'm trying to, just a second here. Let me look at some of the notes because this came from I think this was an FTAC recommendation. And folks from HCA, if you want to chime in while I look for my notes, go ahead.
Yeah, Liz, it might be in the packet that went out to commission members, FTAC's
Yeah.
analysis. It should be described there.
Okay, okay, here we go. Here's what it is, Jane. It's on page 125 of the packet. So reduce the affordability threshold. Could seek a waiver to reduce the affordability threshold from 9% to something lower. For example, based on the level of subsidization currently available under the ACA. This would increase costs to the federal government, so CMS would have to agree, or Washington would need to subsidize additional costs. Is that enough more information on that one? And the idea is, okay, the idea that this person put forward was lowering the affordability threshold could result in more employers facing the mandate penalty.
Okay. I mean, I have to admit, it's been a crazy week for me, and I.
Oh, no. I don't mean to call you out about it. Yeah, you all are very busy, and this is,
I'm just trying to figure, it's almost like, and maybe this is in the materials, so Angela, you can make me look like adult, but to have sort of a who does this apply to, right?
Mhm.
So reducing the affordability threshold, who are we taking the action with respect to?
Can I take a stab at it?
Sure.
Yeah, go for it.
Well, you're looking at like the Affordable Care Act, right? 9% is what's considered 90% of
Oh,
your
I got it.
yeah,
I got it. I got it.
modified
Okay.
adjusted gross income. And so it's based on the person's income. So if we lower it to 8%, then that lowers what we
I
think
got
the
it.
premium should be for somebody.
I got it. And
Great.
then facilitate accessibility of hospital price. Is that like the transparency and coverage rule, but make it so that people can actually understand what the hospitals are posting? Is that what that's getting at?
Yes.
Okay. Rate agency rate normalization. Is that supposed to be state agency? I'll look at all of these. I'm sorry.
That's okay. No, it's I think what we're gonna do, Jane, is I don't know if we're gonna go ahead and vote because I'm going back and forth. Vicky and Mandy and I are going back and forth, and we realize there are probably a lot of questions, and there's a number of folks who are not here today. So I think we'll just go through this and say, if there's anything that's missing, let's flag it now and put it on the list here. And then we can go back and ask questions via email. And I know there is a document in the packet that kind of goes into each of these with a little bit more detail. So does that sound okay with folks? So just right now, we just want to make sure we're kind of throwing everything up in these categories that we think would be important to consider.
And Liz, I think that makes sense.
Okay.
We can go through and do a question and answer and take any missing information from everybody and just have the opportunity to begin our discussions on these topics. And then we can pick this up at the next meeting.
Yeah, we didn't want to overwhelm folks with, already the slide is overwhelming. But we didn't want to overwhelm with another like more detailed slide about each one of these pieces. So it's almost like an appendix to look at and think, okay, that's interesting. And I get what that means. So there's a little more background in the packet. So I would encourage folks to take a look at that. But I think it doesn't sound like there's any other policies or ideas that folks want to put into the affordability cost containment pricing bucket or the capacity infrastructure bucket. Okay, why don't we go to the next slide? Okay, so, these are two other buckets of ideas that were brought forward. The coverage and enrollment bucket. Examples are auto assigning Medicaid enrollment to high quality, lower cost plans, auto enrollment for Medicaid to no premium exchange, et cetera, and then another bucket around providers, trying to bring providers into the system, motivating interest in preventive care and primary care, network adequacy standards. So I'll be quiet for a minute. Is there anything missing in these two buckets?
And, for everybody's recollection, these are just all the ideas collected from you and from EPTAC about short-term solutions. We just put them into categories for your easy visualization of the materials in terms of like what they might fall most relevantly under, and sort of sorted them so you could see them as collected in terms of different categories of options, so that you could either in the end concentrate on a category if you wanted to of options. Doesn't mean you have to pick every one of these options. You could focus in on certain of these options and not do other options. But this sort of helps you, if you want to, select either a bucket to concentrate on or pick certain ones from the different buckets that are most appealing to you. But it's just a way to sort of categorize the information and potential policy solutions.
I don't see any comments or hands raised at this point. But again, you can take a closer look after the meeting at the packet, and Mandy's making the point that what we want to get to is a couple of focused areas. And I think it's really important. I mean, this is a side comment that I was going to mention later, and when we talk about the report, these are really I think the staff and my colleagues at HMA and I have been really impressed with sort of the platform that the commission has, because so much of what you all endorsed in last year's report, there was action taken during this last legislative session. So it's really important to think about what could be beneficial to improving the system now. And so that's kind of an important lens. And I think that was what one of the public commenters mentioned earlier too. So.
Hey, Liz.
Yeah.
Do you want us to just be saying what's missing, or do you want?
Yeah, I think say what's missing, and we can edit the slides and resend it out to the commission for further deliberation. The goal is to be able to get something in the report that you guys are going to send forward for November. Representative Riccelli.
Yeah, can you go back to the previous slide really quickly?
Sure.
Well, I'm just wondering, and I don't know if I'm missing something here, but we did have legislation introduced on the cost transparency board. And I see other states are doing a number of things around that. And I think, it seems like an avenue of potential policy intervention that would make sense to explore under the affordability, cost containment, pricing. And for those maybe following along on TBW, that the bill was 1508 by Representative Macri. And it's still alive in the session, in the biennium. So anyway.
So we could be more specific there and say.
Yeah, and I don't think naming a specific bill that was brought up maybe, but just, we do have this cost transparency board, and I think a lot of people are interested in how that could be maybe improved.
Absolutely. Okay, so strengthen the cost of the healthcare cost transparency board or something like that. Okay, we'll put that on there. Jane.
So the other thing that I'm thinking about is sort of getting at anti-competitive contract provisions. And historically with Senate Bill 5393, we were looking at it from the perspective of provisions in contracts between providers and insurers. But I am hearing more and more about physician consternation, about non-compete clauses when they're in a provider group and then they're dissatisfied with that arrangement and want to leave. And we've also heard some concerns around vertical integration, where you've got entities where a holding company owns an insurer and owns a physician group. And what's the nature of the contracting between the insurer and the physician group, and are there anti-competitive elements there? And I think that given all the attention that's been given to healthcare consolidation, and I can talk to people about the report that we're working on for the end of this year, but some focus on anti-competitive contracting.
Okay.
I think providers is a category. Would that fit, Jane? Would you like to see that under the providers category?
I mean, it relates back to affordability, right? But you can put it, you can.
We can put it in both even.
You can put it anywhere you want it, but it's,
sure,
we're supposed to have a quote unquote market, but if you've got anti-competitive things going on,
right,
then you're sort of, you're altering the way a market, quote unquote, is supposed to operate. So
we'll figure out where it makes sense, and maybe it's in both. And again, this is just for the purposes of being able to sort and make sense of all the things on the table. Okay. Why don't we go to the next slide? Couple other categories: purchasing, consolidate state purchasing, which we've heard, and finally subsidies, expanding the premium tax credit, and expanded health benefit exchange cost sharing subsidies. So we've kind of got the big picture here. Would love to hear if there's any other ideas we need to add. They don't necessarily have to fit into a bucket. We just want to get them all on the table.
Do you want to consolidate and expand state purchasing? No, that's not what I want to
Good.
say.
No, that's, I
Make
think
it-
that's,
Yeah,
that's a good flag. Mhm.
but I'm thinking along the lines of PEB, like expanding.
Expanding PEB.
For small businesses or
Mhm.
nonprofits.
Okay.
Does that?
Okay, we can add that. Anything else? Okay, so we're gonna go through and add what we heard today, and I heard the expanding and consolidating state purchasing for in PEB and SEB piece. Jane's comment about understanding more about what's happening in consolidation with providers. And then Representative Riccelli's comment about the Healthcare Cost Transparency Board and strengthening it. Okay. And I think if there's anything else, please send it along to the staff and we'll make sure to add it. And then we will queue up something via email to try to get y'all to settle on something that we can put forward in the report. And again, those will be the areas that we'll be looking at more closely over the next year. Okay, so I'm going to go really quickly through the report development because I'm in a space where I'm probably going to get kicked out in a minute and I don't want to have to leave you all hanging, but just a quick reminder of where we are with the report. We started earlier this year. Right now you have a draft of the report and we're in the review period and the goal is to vote on this in October. So if we want to go forward to the next slide, please. There's 5 key areas of highlights and the key areas that are covered in the report. It's much simpler than last year, thankfully. We describe the launch of the FTAC. We talk about the effort to adopt equity principles, update on what's going on with eligibility considerations, specifically around Medicare and ERISA. And then as we just discussed, we'll highlight the areas for transitional solutions, and finally talk about how the commission is incorporating the work of the Health Trust. Next slide, please. So for FTAC, we describe for the legislature the work that's been done to bring in national and state experts and the process that's been undertaken there. And really clarify that there is a recognition that there's a North Star, that that we have a unified financing system, but really the FTAC and the commission are looking at ways to, in short of the North Star at this very moment, find ways to achieve parity and improve access, equity, and quality for Washingtonians. Next slide, please. Health equity framework. We talk about the definition of health equity and talk about how the commission has adopted the HCA framework and the decision to use the HCA toolkit to support decision-making. Next slide, please. Finally, we go into describing what the commission decided on Medicare, which is the focus is on achieving coverage and affordability parity by wrapping with additional benefits and exploring waivers in the meantime to achieve that uniform financing system. ERISA at this point, we're just talking about the pathways that we're exploring, and that will be updated before the report is final. Next slide, please. We just talked about transitional solutions, and there will be a mention of that in the final draft of the report, but also just really emphasizing for the legislature the role that the commission can actually play in terms of the platform to help talk about some of the policies that are available and necessary in the short term to moving towards a universal system. And finally, the work of the Health Trust Bill, describing how the whole Washington has come to this commission and is now working closely with staff, and there's a plan to look at the legislation alongside of the topics as the commission goes forward. And that will be putting forward an initial report next summer. So that's that. So thanks to the staff for a great report, and to all of you for your work for making the report possible. So I'll turn it back over to you, Chair Lowe.
All right, well, good timing. Thank you, everybody, for your participation today, and the meeting is adjourned. Have a great evening.